How many of you routinely do many cardiac MR studies? And how many do any? Okay, so just a very small number. And what I'm going to go through right now is the number of cases in cardiac MR. And first I'll show you the case and then we'll discuss. And I'm not going to be showing you a lot about how to do it or techniques because I suspect that many people don't necessarily need to know all of that, or many people in this audience don't necessarily need to know all the technical aspects, but may be interested in case you see some cases or in case you get referred some case. So I'm going to start out first with acquired heart disease, and towards the end I'll discuss congenital heart disease. Okay, so the first case is of a 58-year-old woman with a 2 to 3 month history of dyspnea on exertion and lightheadedness when changing position. So what do we see here? Well, on the spin echo T1 weighted image, there is this mass in the right ventricle, and it's of moderately high signal intensity. And on the T2 weighted image, it's a very bright and uniform. It's homogeneous. It enhances heterogeneously with gadolinium, and it's bright on the T1 weighted images. It's bright on the Cine GRE image. Now, first of all, what is the most common mass in the heart? It's a thrombus. But what do you think this diagnosis would be? Was it a thrombus, a primary benign tumor, primary malignant tumor, or secondary tumor? Well, first of all, I can tell you thrombi don't enhance, and this mass was enhancing. So it's not a thrombus. It's either a malignant tumor or a benign tumor of the heart. Now, let me just go over different types of locations of tumors. This is an intracavitary tumor, and you can see it's occupying the left atrium. This is a myxoma. And remember that the tumor that we have, the mass that we have, let me just go back to it, is intracavitary. Okay. This is an intramural mass. This is an angiosarcoma, but metastases, hematogenious metastases, can also look like this. And what type of metastases go to the heart? Well, there are several major primary tumors. These include lymphoma, breast cancer, lung cancer, and melanoma. This is a pericardial tumor. It's a big mass. It's heterogeneous, and it happens to be a hematoma in the pericardium. And notice this is the pericardium, that black line right there between the two layers of fat, the black line, and it goes around this. This is a pericardial tumor. This is pericardiac adjacent to the heart. It's not in the pericardium, it's next to the heart. This is a lipoma with high signal intensity. Now, what is the technique that we use for MR? For most cardiac MRs, this is the standard technique that we use. We use coronal spin echo, axial spin echo with ECG gating. Both of these are with ECG gating. Then we may use gadolinium, especially if we're looking for a mass, for constricted pericarditis or hypertrophic cardiomyopathy. Gadolinium helps. Then we finish off with a Cine, and that's a GRE type Cine. Now, how do we tell malignant tumors from benign tumors? Well, malignant tumors have a wide point of attachment. They may have necrosis or cavitation, involve more than one chamber, and extend beyond the heart. You may see pericardial effusion and pulmonary metastases. So essentially, these are infiltrating, irregularly marginated tumors that tend to extend outside of the heart. And this tumor that we have here, it has a wide point of attachment, but it's well marginated. It's involving only one chamber, does not extend beyond the heart, smooth margins, and no pericardial effusion. This is a benign tumor. And this particular one is rare. This is a hemangioma. But on MR, we're not going to make specific diagnoses of the types of tumors. What we can do is differentiate benign from malignant tumors and differentiate tumor from thrombus. Okay, and the patient has to undergo a biopsy, or either an endomyocardial biopsy or open biopsy, in order to make the specific diagnosis. Let's look at a couple of other tumors. Wide point of attachment here, extension outside of the heart. Look there, it's extending through the wall of the heart. It's irregularly marginated, it's lobulated here. This is an angiosarcoma. That's the most common malignant primary tumor. Different case, I showed you this one earlier. It's organized, a subacute pericardial hematoma, and this one is an old one. Now, how do you differentiate hematoma from tumor? Hematomas do not enhance. Tumors do enhance. You may see homogeneous or heterogeneous enhancement from a tumor. Hematomas won't enhance. The other thing is, on a GRE image, tumor will be intermediate, whereas thrombus is dark. Let's go on to another study, another case. 50-year-old man with peripheral edema and dyspnea on exertion. He had previously had cardiac surgery. So what do we see here? Well, first of all, on this coronal view, we see marked thickening of the pericardium. Notice that this is, there are two layers of fat on either side of the pericardium. The layer of fat adjacent to the heart is called the epicardial fat. The layer of fat outside of the pericardium is called the pericardial fat. And these two layers can be seen sometimes on plain film, and if there's a pericardial effusion, especially on the lateral view, you may see what's called the fat pad sign, indicating that there's fluid in between these two layers of fat. But if the pericardium becomes thick, as in this case, then that is abnormal. What else does this particular individual have? There is marked narrowing of the right ventricle, and the inferior vena cava is very large, and there's also ascites. So these findings are consistent with a specific diagnosis, constrictive pericarditis. If the pericardium is thick, 4 millimeters or greater is abnormal, then that can be consistent with constrictive pericarditis in the correct clinical setting. So when might you see a patient like this? Well, the patient may have constrictive restrictive physiology, which is a clinical diagnosis, and they can confirm that with echocardiography and with cardiac cath. But it's difficult to distinguish constrictive pericarditis from restrictive cardiomyopathy. Both of these entities have constrictive restrictive physiology. Constrictive pericarditis can be treated surgically with pericardial stripping, which is relatively straightforward. Restrictive cardiomyopathy, on the other hand, requires a heart transplant if you're going to treat. So it's important, when you get the patient referred, constrictive versus restrictive, to do an MR and look for pericardial thickening. 4 millimeters or greater is abnormal. And if you happen to see pericardial thickening in some random patient on CT or MR, that is not constrictive pericarditis unless they have that particular physiology. So they have to come with the clinical question: does this person have constrictive pericarditis or restrictive cardiomyopathy? Then you can do the MR or CT. And we usually do MR because the images are much clearer. So what is the diagnosis? Well, in this particular case, it's constrictive pericarditis with the pericardial thickening. Okay. You may see, other than pericardial thickness, you may see ancillary findings such as right atrial enlargement. There's usually no RV enlargement. Usually the RV is narrow, and the IVC and hepatic veins can be markedly dilated. What are the etiologies of constrictive pericarditis? Well, this actually used to say 20th century until a couple of years ago, but now I just changed the slide. Now, what are the etiologies in the 21st century? Well, cardiac surgery is the most common cause of constrictive pericarditis in the United States, followed by radiation therapy. Other causes are viral or uremic pericarditis and tuberculosis, which is the most common cause worldwide but unusual in this country. Let's go on. 56-year-old physician with exertional syncope and ventricular ectopy. Okay, so what do we see? We see in the right ventricle, notice this this area of fat in the right ventricular myocardium. The myocardium should be homogeneous like this, but there is a high signal intensity area, and there are other little dots of high signal intensity in the RV. In addition, there's marked wall thinning in various areas of the right ventricle, such as here and here. This is consistent with right ventricular dysplasia. If you see wall thinning and fat in the RV. These patients usually have a wall motion abnormality as well. They have poor contraction. So what's the diagnosis? Right ventricular dysplasia. How many people have heard of that before? Okay, well, quite a few. Actually, I had never heard of it until I started doing cardiac MR. Okay, maybe I was just a bad resident. But okay, so the technique that we use is slightly different, and it's actually evolved recently. We start out with the sagittal image mainly as a localizer, and then we do axial images and axial cine. If you have double inversion recovery, you don't have to use this posterior saturation band, but if you don't, then I would put on a posterior saturation band. And let me see if I can show that here. You see how the posterior aspect of the heart is saturated out with this band, which is about 50 to 60 millimeters, 5 or 6 centimeters thick, this band. And that is done to reduce any artifact from cardiac pulsation. We do EKG gating, but even with that gating, there's a little bit of pulsation artifact. Okay, and then we do the cine in order to look at the wall motion. Nowadays, we've started actually to do post-gadolinium images, but that's still a little bit experimental. We're not sure whether it's going to help us. So what is the clinical syndrome of arrhythmogenic right ventricular dysplasia? Well, patients present with recurrent ventricular tachycardia or PVCs of right ventricular origin. So that's an EKG finding. Occasionally, you may see young patients who have a history of sudden death during exercise. And sudden death means cardiac arrest, so they may be revived. And if they weren't revived, then they go to autopsy. Now, right ventricular dysplasia can be sporadic or familial. About 50% of cases are run in families. But the inheritance is complex. It's not a simple inheritance. So because of that familial predilection, you may get cases of MRI. You may be referred patients who have a family history of right ventricular dysplasia. So that family member either was diagnosed or died and had an autopsy showing right ventricular dysplasia. And they come in for screening. Now, what is RVD? How does it occur? Well, first of all, it's idiopathic, and it represents fatty or fibrous degeneration of the right ventricular myocardium. So you may get fatty infiltration of the myocardium or fibrosis of the myocardium. So the fatty infiltration seen on MR indicates there's fatty degeneration, and if you see wall thinning and wall motion abnormality, that indicates fibrous degeneration. And MR is one of several criteria. It's a complex diagnosis, but MR is an important criterion to use. Okay. Next patient, a 62-year-old man with exertional chest pain. Evaluate for coronary artery disease. Okay, so what do we see here? This is a first pass study. So in other words, what we're doing is injecting gadolinium, and we're getting multiple images, one after the other. And normally what should happen is that the myocardium should enhance like this. This is the LV, this is the RV in short axis. Let me play that again. Okay, notice the chambers are enhancing. Now the myocardium is enhancing. But there's one area down here that's not enhancing. There's a subendocardial perfusion defect in the inferior wall. Okay, so what are the MR techniques for the identification of coronary artery disease? These techniques are just being implemented now. Centers across the country are now starting perfusion MR imaging as well as wall motion functional imaging of the heart. And so what I mean by function is wall motion. Okay, we look at the cine images and see if the wall is moving normally. So we use wall motion imaging at rest and stress. We usually use dobutamine as the stressing agent, because normally it's difficult to ride a bicycle while you're in the magnet. Although there are some centers, especially in Europe, that have set up a bicycle-type system in the MR suite where the patient can lie supine and exercise, but it's really cumbersome, as you might imagine. Probably not too easy for the patient. So we usually use dobutamine. We can also do rest and stress perfusion and coronary blood flow imaging as well. So, a different case. Well, one thing I want to talk about the perfusion. Why do MR instead of nuclear medicine? Well, one of the things is MR tends to perform a little bit better than SPECT nuclear medicine, like thallium imaging, thallium or sestamibi imaging. It's similar to the performance of PET in terms of sensitivity and specificity, but better than SPECT. And if the SPECT is of good quality, of high quality, then MR probably isn't going to add much. But there are certain patients who have a moderate quality SPECT, especially if they have soft tissue overlying or other artifacts, in which case an MR may be beneficial in those types of patients where the SPECT is not of the highest quality. And MR has an advantage over PET and SPECT in that we can see, we do get better spatial resolution, so that subendocardial abnormality that we saw here is resolved quite nicely on MR, whereas on PET or SPECT it might be much harder to see, and you may not see that defect as clearly because it's only involving a small portion of the myocardium. And the early perfusion defects occur right there. So MR tends to be quite sensitive and can localize it as subendocardial. Okay, next patient. Okay, so you know, you guys are actually lucky. I actually forced my residents to take these cases and discuss them, but I think I'm doing you a favor. Maybe not. Okay, a 67-year-old man with a history of multiple myocardial infarctions. And he's currently undergoing evaluation for CABG or cardiac transplant. So multiple myocardial infarctions. So what do? We do short axis cine, and then we did a T1 weighted sequence after gadolinium. This is called viability imaging, in which case what we do is combine the wall motion, which is the cine, with the delayed meaning 7 to 10 minutes later, the viability imaging, delayed contrast enhancement. So what do? We inject contrast and do the first pass perfusion scan, which I showed you on the prior case. Then we do the wall motion, the cine, and then we do the viability study, so there's some delay between the time of injection and the time of the viability study. So what do we see here? This is the cine image showing normal wall motion in this portion of the ventricle. Notice that there's marked thinning of the apical portion of the septal wall and marked thinning of the apex. There's very thin myocardium. And here we see nice contraction, normal contraction laterally and along the proximal septum. Here there's poor contraction. There's actually bulging out during systole, especially at the apex. So there's dyskinesis. And that indicates that there's a wall motion abnormality, a functional abnormality with dobutamine stress, and suggesting that this person may benefit from a CABG or from PTCA, from an angioplasty. Now, how can we tell whether the patient can benefit? Well, if the tissue there, if this tissue is viable, in other words, if it's live, if it's living cells but ischemic cells, then reperfusion will benefit the patient. A CABG or PTCA will benefit the patient. If this area is dead, non-viable, it's infarcted, then even if you take even if you improve the blood supply, you're not going to get improved function. So what we're going to do is test, is this viable or not? If it's viable, the patient can have reperfusion. If it's non-viable, the patient can't have any improvement, even with reperfusion, so there's no reason to treat. And what do we do? On this viability study, this is delayed enhancement, 7 to 10 minutes after gadolinium. Uh, Viable tissue does not enhance. Dead tissue, non-viable tissue enhances. What is this? Is this viable or non-viable? Well, we do see enhancement here. Do you see this? This white area here? This is not viable, and the patient will not benefit from revascularization. Okay, so 17-year-old boy with a history of influenza, and chest radiographs were performed to assess for the possibility of pneumonia. We saw a mediastinal mass on that chest radiograph. So, excuse me. Well, you know, my father is a cardiologist, and I hold cardiologists in high regard, but I do have to say that once they grab hold of a patient, they don't let them go unless they have to. And rather than getting other imaging on this patient, like a CT, what they did was an echocardiogram. And echocardiography was done because they thought, could this be a vascular mass? But that's probably not the best thing to do when you get a mediastinal mass. So what did echo show? No blood flow in the mass. So then they sent the patient to MR. Okay, so we see the T1 weighted image here, T1 weighted with gadolinium. There's no contrast enhancement. So what masses, what pericardial or pericardiac mass will not enhance? Well, a hematoma. But there's one other mass as well. You can see on the T2 weighted images, there's high signal intensity. This is fluid. So this is a pericardial cyst. So a pericardial cyst is another type of mass that will not enhance. And quite easy diagnosis. On CT, one caveat is if you see a relatively high density mass, for example, 60 Hounsfield units, that could still be a pericardial cyst. It does not have to be fluid density. So if you see a high density mass, how do you know whether it's a cyst or a solid mass? Well, you have to do pre and post contrast imaging. Most people don't do pre-contrast imaging for chest CT. They don't do pre and post for mediastinal mass. They just do they just do post. At least at our institution, we only do post contrast for most mediastinal or most chest type CT scans. So MR is quite definitive with the diagnosis. Okay. I think I actually gave away the diagnosis already, but it's a pericardial cyst. And differential diagnosis for the mass would be metastasis or lymphoma, especially without seeing this fluid intensity on T2 weighted images. When I first saw this image, I thought, oh, this is definitely a lymphoma. Even though it's not lobulated, this could still be a lymphoma. But it didn't enhance, so I thought unlikely to be a lymphoma. Okay, so pericardial cysts are benign. They don't enhance on CT or MR. They tend to be bright on T2 weighted images. And the differential diagnosis is a bronchogenic cyst or thymic cyst, essentially a benign cyst. We call this a pericardial cyst based on the location. Most pericardial cysts are actually in the cardiophrenic angles along the diaphragm, but some of them, 10%, are away from the diaphragm. Okay, next patient, a 28-year-old woman with exercise-induced syncope. So what causes exercise-induced syncope in a young patient? Well, right ventricular dysplasia, as we talked about earlier, hypertrophic cardiomyopathy, which you might know as IHSS, idiopathic hypertrophic subaortic stenosis. And the third thing to consider, the third most common thing, is anomalous coronary arteries. And then there's a whole host of really rare abnormalities. So what do we see here? Well, first of all, there's marked thickening of the interventricular septum. So what does that suggest? This is characteristic of hypertrophic cardiomyopathy, IHSS. Hypertrophic cardiomyopathy is usually, 90% of cases have asymmetric septal hypertrophy, meaning the septum is very thick and hypertrophied. The rest of the LV is pretty normal. And 10% have a different distribution, either apical hypertrophy or concentric. And the differential diagnosis here is an angiosarcoma. Remember I showed you a case earlier with an angiosarcoma right in the middle of the septum. So a tumor or a metastasis that's sitting right in that septum. Now a 28-year-old woman, unlikely to have a malignant tumor. But in older patients, that could well be the case. And how do we differentiate? Well, what we do is do a post-gadolinium image There's no significant abnormal enhancement in that area. This is hypertrophic cardiomyopathy. Malignant tumors should enhance intensely. Okay, so you give gadolinium. Enhancing masses are either a metastasis or less likely a primary sarcoma. Okay, so hypertrophic cardiomyopathy is the diagnosis. So hypertrophic cardiomyopathy presents as syncope or sudden death, often exercise-induced. Now, 90% of patients, as I said, have asymmetric septal hypertrophy, and indications for MR include measurement of the LV mass. We can measure precisely what the mass of the left ventricle is. In other words, the weight in grams of the left ventricle. And the volumes of the left ventricle to look at function, like ejection fraction and things like that. We can assess the distribution of hypertrophy. For example, if it's asymmetric hypertrophy, the older type of treatment was surgery. Nowadays, they're actually starting to do alcohol ablation of those of the hypertrophic cardiomyopathy of the septum. They inject alcohol to ablate the septum. Whereas if it's concentric hypertrophy, those patients aren't candidates for alcohol ablation. And we can also distinguish hypertrophic cardiomyopathy from tumor by injecting the gadolinium. And I showed you this case earlier. This was the angiosarcoma that's in the septum, interventricular septum. And pre-gadolinium, it almost looks like hypertrophic cardiomyopathy, asymmetric septal hypertrophy, but there is this intensely enhancing mass. This is a tumor. Different appearance of hypertrophic cardiomyopathy in a child. Sometimes this includes the right ventricle. You see how thick the RV is? And this is concentrically involving the left ventricle. Look how small the LV chamber is. On the sagittal view, same thing, LV and RV. Diffuse myocardial thickening. Different patient. 38-year-old man with chest pain. Okay, so what do we see here? Well, first of all, notice that there's marked enlargement of the ascending aorta and aortic root. This is a specific type of aortic aneurysm called annuloaortic ectasia. And this is the pathological entity here is called cystic medial necrosis, and this results in annuloaortic ectasia. What are some causes of this? Well, it could be idiopathic, but it's also associated with a connective tissue disorder such as Marfan syndrome or Ehlers-Danlos. And this person did have Marfan syndrome. So this is a characteristic appearance, the tulip or bulb shape of the aorta. And these get very large. There are three risks of annuloaortic ectasia. The least significant or least important one is aortic insufficiency. The valve becomes dilated. So there's aortic insufficiency. And the worst ones, the life-threatening ones, are dissection and rupture. So rupture, most patients will die immediately. And dissection, these patients can survive. Usually dissection starts right at the valve and goes up. And this person came in with acute severe chest pain radiating to the back and absence of the right radial pulse. So what did he have? He actually has a dissection flap here in the aortic arch. And the innominate artery, the right brachiocephalic artery, is involved. We only see a nubbin of it right there. And that would explain the absent right radial pulse. So this is an unusual dissection. Now, this is considered to be type A because it's proximal to the left subclavian artery origin. Type B is only distal. Type A dissections usually go to surgery. Type B dissections are managed medically. And why is that? Because type A dissections have 4 life-threatening complications. And what are these? Well, first of all, they can get pericardial effusion and tamponade, rupture of the aortic valve and aortic insufficiency, or involvement of the coronary arteries or carotid arteries resulting in MI or stroke. So life-threatening complications if it's proximal to the left subclavian artery. Type B dissections distal are managed medically. These are managed surgically. They remove the ascending aorta. Now, why did they do the angiogram here? Okay, it pretty much shows the same information. huge aorta, annular aortic ectasia, dissection flap is right there. Innominate artery is very poorly seen and suggesting involvement. Well, this is one of the first MRAs that we did, and the surgeons didn't believe it, so they ordered the angiogram. But actually, thinking about this, every time I see this case, I think this is a crime to do this. Why? Because, first of all, you can tear the dissection flap with the catheter. So nowadays, thoracic aortic angiograms, thoracic aortography is usually reserved for trauma cases. It's you may do a CT, and you can do the angio in conjunction with the CT scan in trauma if necessary, if the CT doesn't answer all the questions. But you shouldn't do it for dissection if you have access to CT, MR, or transesophageal echocardiography because of the risks and lack of necessity. Okay, so this is the aortic dissection. And what is the value of MRTE and TEE and helical CT? Well, there have been a number of studies over the years, and recently helical CT has been shown to have very high sensitivity and specificity, as good as MR, which was established perhaps 10 or 15 years ago, and then helical CT came along in the past 10 years. Transesophageal echo is also used, especially in the critical setting where the patient can't be moved to radiology, and in the OR, for example, once the patient's diagnosed with a dissection by CT or MR, the patient goes up to the OR for a type A dissection. Then they look at the valve, the aortic valve, to see if that's involved in the function of the aortic valve. And they look at other things at the time, just before surgery. So TEE tends to be used too often, and I would recommend using CT or MR. You don't have the choice. As I said, the cardiologists, once they grab hold of the patient, they don't like to let them go. And the problem with using TEE is in the ascending aorta, there may be limited specificity depending on the patient. You may lose specificity, in which case you're overcalling type A dissections and you're sending too many patients to surgery. So patients who only get a TEE may go to unnecessary surgery based on these relatively lower specificities. Actually, a specificity as low as 67% has been reported in the ascending aorta. So it's better to do MR or CT, and if necessary, they can get a TEE in the OR if it's a type A dissection. That way you will send fewer patients to surgery unnecessarily. Okay. Next patient, a 72-year-old woman with progressive dyspnea. Okay, so what do we see? On the cine image, normal flowing blood is white. If you see any black flow jets, that indicates an abnormality of flow. We can see this ascending aorta here, left ventricle here. Notice this black flow jet emanating from the ascending aorta into the left ventricle. This is a regurgitant jet. So this person has aortic stenosis. We can actually see that on the cine, on this coronal image. Notice right there, this black flow jet propagating into the left ventricle. This is aortic insufficiency. Okay. Okay, so I'm just going to do a few more minutes on congenital heart disease. And then I'll finish up and let Mike Galway continue his talk. Or I'll let Mike Galway do his talk. Okay. Okay. So this patient, 12-year-old girl with a history of recurrent hypertension after repair of coarctation of the aorta. Okay, so coarctation is repaired usually during infancy. And what happens is that the repair site does not grow with the rest of the aorta because the repair site is artificial and it's not going to grow. So what can happen is that site can become stenotic and cause recurrent coarctation. So what do we do for coarctation of the aorta? Start out with axial images like this. This is the ascending aorta. The distal arch is markedly narrowed. We do these oblique sagittal images in that plane. We open up the aorta like this. We see the ascending aorta, the arch, and the descending aorta. And here, this is a moderately severe, discrete juxtaductal coarctation. This is the most common type of coarctation of the aorta. It's discrete and juxtaductal, meaning it's next to the ductus, or the ligamentum arteriosum. And as I said, this frequently occurs after repair in infancy. A substantial minority of patients do get recurrent coarctation in the teenage years or adulthood, young adulthood. So what technique do we use? We do a sagittal series, an axial series, an oblique sagittal through the ascending and descending aorta, and then velocity-encoded cine MR, which is a flow measurement technique. We also do MRA quite routinely. So what do we do for our MRA? We use as low a TR and TE as we can get, 28 to 40 slices, 0.5 necks, and breath hold is usually about 20 seconds, and double dose gadolinium in children. It usually turns out to be approximately 15 to 20 cc's of gadolinium, depending on the age, on the weight of the child. In adults, we'll use usually 20 to 40 milliliters. So, what are we looking for in coarctation? Site severity and extent of the lesion, collateral flow measurements to assess the functional significance of the coarctation, and post-treatment evaluation. So different patient with coarctation. Notice in this individual we have to look at multiple different images to see the entire aorta. We can't see the entire aorta in a single image here. But we do see this discrete juxtaductal coarctation. One of the advantages of MRA is that we can do these reconstructions and show the entire aorta on a single image. And the clinicians love this type of appearance. For those of you who routinely do MRA, I'm sure you know that. And you can see here collateral vessels as well up here. Different patient long segment coarctation. This is an unusual type of coarctation. The MRA shows the long segment, but in addition, these huge dilated vessels. And that's one of the advantages of MRA. We can see those collaterals. Now, we can actually measure the collateral circulation. And how do we do that? With a technique called velocity-encoded cine MR. This is velocity flow mapping, a phase contrast technique. I'm sorry. Let's say we want to... Let's say we want to measure the aortic blood flow right there in the descending aorta. So we want to measure how much blood goes across the aorta at that point. Well, we take velocity-encoded cine MR, we prescribe it in an orthogonal plane perpendicular to the direction of blood flow. We get magnitude and phase images like this. It's a cine study, so we're getting 16 magnitude and 16 phase images. This is done for anatomy. This is done for flow. This gives us quantitative flow information. And the flow is equal to the mean velocity times the area of the vessel. The computer does all this for you. You don't have to know all these particular formulas if you're doing these. And as I said, we get 16 phases, multiple different segments throughout the cardiac cycle at one location. And we get a flow curve like this, meaning time, flow, this is the amount of flow versus the time during the cardiac cycle. Most flow in systemic arteries is during systole, and there's very little flow during diastole. So let's come back to coarctation. There's no coarctation here. If we measure blood flow in the proximal aorta, it looks like this. Sort of looks like the NASDAQ market, doesn't it? Now, compared to the distal aorta, and it looks like this. It's slightly lower. So the proximal flow here is slightly greater than the distal flow. Why is the distal flow slightly lower? Because let's say there's no coarctation. The intercostal arteries take blood away from the descending aorta. That's normal. However, in patients with a coarctation, the intercostal arteries bring blood in to the descending aorta. These serve as collateral pathways because very little blood is going across there, and the blood is coming in via the collaterals. So let's look at this patient with a severe coarctation here. And this is not an interrupted arch. It's simply that that part was not imaged on this particular tomogram. So there's a severe juxtaductal coarctation. Measure the proximal blood flow. we see a flow like a blood flow curve like this. The distal blood flow is depicted here, and there's marked increase from proximal to distal. That's abnormal flow, indicating that there's retrograde circulation, bringing blood into the descending aorta. The space between those two curves is considered the amount of collateral flow, and we can actually quantify it as we're doing here. The computer does all of this for you, and we can see that there's an 85 increase from proximal to distal. And any increase, we say any increase from proximal to distal is considered abnormal, functionally significant, and the patient should get further treatment. In other words, nowadays they can get an angioplasty and stent placement, or some patients may need surgery if the stent placement's not appropriate for that individual. I think I'll finish up with that. I hope that was a quick review of different applications of cardiac MR, primarily based on the cases that you might see as opposed to plotting through technique, which is, I think, pretty uninteresting. Thank you for your attention.